It's a pleasure to introduce the third speaker, Mr. Sheikh Ahmad, MB, MCH, FRCS England, FRCS Ireland, and FRCS England, General Surgery. He is cosmetic breast and soft tissue surgeon, aesthetic and oncoplastic breast surgeon, and general surgeon from the Royal Cornwall Hospital, NHS Trust, UK. He is a member of the British Association of Surgical Oncology, Association of Surgeons in Training, and chairman of the Breast Network for Peninsula region in the United Kingdom. He is a specialty lead and director of the breast unit at the Royal Cornwall Hospital. He has made enormous improvements to the unit and transformed it into a modern and up-to-date unit, which has become one of the busiest and the best centers for breast surgery in the United Kingdom. His subspecialty interest is aesthetic and reconstructive breast surgery. Ladies and gentlemen, Mr. Sheikh Ahmad will speak today on multidisciplinary approach to management of breast cancer. Over to you, Mr. Sheikh Ahmad.
Thank you for that very complimentary introduction. So I have been asked to talk about, and I'm very privileged to be invited to this occasion, and talk about multi-professional approach to breast cancer management. Now, how do we do that? Should I start here?
Right. Oh, thank you for inviting, and I'm really honored to be here to talk about multi-professional approach to breast cancer management. In UK, we approach this by multidisciplinary team. Multidisciplinary team is basically a group of professional or medical professionals from different disciplines who come together to talk about a patient and management and diagnostic approach. This is how the MDT looks like in this modern era. You can see there are a lot of people sitting there. They belong to different speciality, and then in front of them there are a couple of screens, and these screens are projecting radiology, and on one screen there will be histology projected. It usually takes place once a week and lasts for about 3 to 4 hours. Prior to introduction of MDT, the fashion was to do inter-specialty referrals, talk to your colleagues in middle of the corridor or a cup of tea about patients, and that used to lead to a great waste of time and delay in treatment, and usually would end up in frustration from both sides, patients and surgeons. But in 1995, Kalman Hine report suggested that there should be more to just one surgeon or one clinician delivering the service, and there should be inclusion of non-surgical oncologists. But actually, this report was further enhanced and supported by several other reports, and since then, the introduction of multidisciplinary team was introduced into National Health Service. The reason for doing all this is breast cancer is actually the most common cancer for women. 1.7 million women are affected all over the world, and 500,000 women die after secondary to breast cancer. Incidence has increased several folds, although the mortality has decreased, and decrease in mortality is due to optimal management of patients, and partly it is due to introduction of MDT. Incidence varies from areas to areas, the highest incidence being in Western Europe, which is approximately 100 per 100,000 patients, and lowest in areas like Eastern Europe, where it's around about 16 to 20 per 100,000 patients. Mortality also varies, and it is really strange. The mortality in Central and Eastern Europe is as high as in certain part of Africa. So what are the benefits of MDT? MDT allows all key professions to jointly come together and make a plan or contribute to decision-making process in patient care. MDT provides consistent, coordinated, and a cost-effective care of the patient. Decisions made by MDT are more likely to conform to evidence-based guidelines than those made by individuals. MDT meetings are perceived to be effective in medical management of patients with advanced breast cancer. And in literature, it has been shown that MDT contribute to short mean time from diagnosis to treatment, which has got significant p-value. So from 42 days, it goes down to approximately 30 days from diagnosis to treatment. It is a very good teaching tool for junior and trainees. And it has been estimated that since the introduction of MDT in 1995, the majority of the patients are being discussed, and in 2004, 80% of the patients were discussing MDT, and currently, every patient is discussing MDT prior to their treatment. And eventually, the situation is that MDT treats the patient, not an individual clinician, which is good in a way because all the benefit goes to patient, but in a way for clinician, it is a little bit of downside because clinicians at times feel a little bit helpless because they have to rely on MDT, which is once a week, to make a final judgment and decision. Components of MDT are various disciplines. We will talk about that in great detail, but having all these disciplines under one roof or in a room does not really do anything unless there is good communication. A good communication is essential, a key element to having a successful MDT meeting. So we have core members, which are breast oncological surgeons or oncoplastic surgeon, which is a new breed which I think UK was the first to introduce, but it is spreading all around the world now. Radiologists, pathologists, and oncologists. Breast care specialist nurses and plastic surgeons, which are not as important as they used to be since the introduction of oncoplastic surgeons. Supporting members, trainee doctors, clinical trial nurses, radiographers, geneticists, psychologists, and patient relatives. Now, literature has suggested that patient relatives is a good element to have in the room, but it has been quite convincingly opposed by surgeons in UK, and hence in our MDT there are no relatives or patients. So let's talk about different components or different speciality in MDT. Radiologists, most important component in triple assessment. They are key to the diagnosis of breast cancer. Usually it is the first imaging modality is ultrasound and mammography. Ultrasound we usually perform on any patient who's less than 40. Above 40, they get both ultrasound and mammography. In majority of the cases, these are more than enough, and we get the diagnosis, but in certain cases when the breast density is very high or the image is radio occult, MRI is performed to get more detail on the lesion. Radiologists give information on the site, size, and multifocality of the lesion. Information on malignant calcification, which is very important because it can play a major contribution towards what kind of surgery the patient will have. Information on the state of axilla, which is essential to the assessment of breast cancer. Every patient who is diagnosed to have breast cancer, i.e. invasive or DCIS, have an ultrasound of axilla. Post-surgical specimen X-ray. Now, most of the departments or most of the hospitals will have flexitron, which is an X-ray machine lying in theater, and once the specimen is taken out, it is X-rayed straight away, and the radiologist looks at it on a digital monitor and tells whether radiological excision is complete or not. Decision to localize a small incidental lesion or screen detected lesion is also taken at the time of MDT meeting. The second A member of the core team is pathologists who play a key role in accurate and detailed diagnosis of the cancer, and all tells us about the grade and the vascular invasion and the receptor status, which can play a part in deciding whether the patient should have neoadjuvant chemotherapy or should have surgery first. Information on the surgical margin clearance is very important, and currently what we practice all over the country, but not in agreement most of the places, is that anterior and posterior margin are irrelevant, because anterior is skin, which is not part of the breast, and posterior is muscle, which is not part of the breast. But we look at the rest of the margin, which is superior, inferior, median, lateral, and for DCIS we aim to remove 2 millimeter of healthy margin around DCIS, but invasive disease we just have clear margin in our department. Oncologists, MDT, they are the cancer expert. They know everything about cancer, and we rely heavily on them to give us adjuvant treatment or neoadjuvant in certain circumstances. Breast cancer survival has mainly proof due to oncological treatments. A phenomenal amount of progress has been made. The amount of money which is spent in breast cancer research is more than any other, or in fact collectively in other surgical specialties. Their contribution to targeted therapy is very important these days. For example, trastuzumab, which is extremely effective in getting us a complete pathological response in neoadjuvant scenarios. Decision regarding adjuvant and neoadjuvant is made in collaboration with oncologists. Triple negative young patients or HER2 positive are offered invariably neoadjuvant chemotherapy. Post-surgical radiotherapy and hormone treatment is pretty much standard in most of the cases where it is small early cancer and hormone positive. However, in more complicated patients, further input is required from the oncologist. Role of surgeon, they usually are leading the MDT. They correlate all the findings from different specialty, helps MDT to make a decision about the surgical management, perform the oncological procedure with aesthetic consideration, and correlates post-op information and helps MDT to make decision about their adjuvant treatment. Breast care nurses. I cannot emphasize more about the importance of these women. They have an immense contribution. They are very important and facilitate the understanding of management process for the patient and their journey through the disease process and in follow-up. Now, as MDT has developed over the last 10-15 years, there are new sub-MDTs are being evolved, which are helping to manage these patients more effectively. An oncoplastic MDT, which is now essential component of any oncoplastic unit, has oncoplastic surgeon, trainee surgeon, and reconstruction nurses. A family history MDT, which takes place once a month, has oncoplastic breast surgeon, geneticists, psychologists, and family history breast physicians. Now, oncoplastic surgeons MDT, which is once a week, separately discuss all the reconstruction patients. We, in our unit, perform around about 80 mastectomies with immediate reconstruction, and these mastectomies are mostly ultraskin sparing, which means they are nipple-preserving mastectomies. Approximately 200 therapeutic mammoplasties are done, which were cases usually would be dealt by wide local excision, and incisions and placement of the incision was not a very important factor, but now most of these wide local excisions have been replaced by therapeutic mammoplasties, which give absolutely fantastic results with no residual gap or minimal defect in the breast. So breast reconstruction has evolved with patient requirement, their desires, their ambitions, and modernization and new techniques. Our own practice has drastically changed over the last 5-10 years. And 90% were autologous reconstructions, LD flaps, tram reconstructions in 2010. The ratio has completely reversed in 2014, and now we do implant-based ADM-assisted reconstruction, which has a minimal recovery period. Operation time is decreased to 2 hours. We perform more surgery, and patient satisfaction is higher as compared to flap reconstructions. We do continuing analysis and data auditing when we introduce a new technique, and after introducing this technique about 5-6 years ago, we have data to show that this is a very compatible technique and good for the patients. And we also look at health economics, and health economics, when is exercise, it shows that doing reconstruction with minimal intrusion to body system and physiology produces both results from patient perspective and surgeon perspective. Now, this is an example of therapeutic mammoplasty. This patient has got 2 centimeter cancer in the upper outer quadrant, right breast. If I take it out in a small breast like this, it's most likely going to leave a big defect. This is marking for therapeutic mammoplasty. This is the next step where the gap has been opened. This is the cancer being removed from upper outer quadrant completely, and then the flap is mobilized and moved into that gap, and then breast is closed, giving us a breast without any residual defect. This is a very popular technique in UK, and most of the cancer being excised by this technique, even if they are in the remote areas from the flap. ADM-based reconstruction is, ADM stands for acellular dermal matrix. They are very expensive, usually derived from porcine skin. Costs around about £1,800 plus VAT, but as the new products are coming, this is becoming cheaper and cheaper. But this is an example of ADM reconstruction and the results you can get from it. This is a patient who had DCIS excised by a linear incision in the inner lower quadrant, but DCIS was very widespread. All the margins were involved. He opted for mastectomy. Mastectomy, ultra-skin sparing mastectomy, is usually now we do through a lateral incision. This is a ultra-skin sparing mastectomy, which takes about 1.5 or 2 hours in a medium to small size breast. And this is after mastectomy and sentinel node biopsy. We haven't done anything yet. In the next slide, you can see that, I don't know if it's very visible or not, but muscle has been lifted. This is muscle on the top, this is head end, and this is mesh. And this mesh is not expensive. This mesh is not as expensive as ADM. You can get it for £150. So on the top, pectoralis major has been lifted, and the lower part is going to be covered by this mesh. And then implant is inserted, and that's how it looks. The mesh is draped at the lower pole to give the natural look. And this is closure. And this is patient after 2 weeks. And this is patient after 6 months. This is a new technique called draping technique. You allow the whole prosthesis implant to fall into the breastosis, so the patient doesn't require any contralateral surgery. This is another example, a lady 65 who had widespread DCIS in left breast, had a mastectomy through a small incision on the lateral side, and ADM-based and implant-based reconstruction was performed. These people are discharged within a day. They are up and about doing their routine stuff. Maximum time they are off work, if someone is working, is about 2 weeks. Sometimes we have to excise nipple, as in the preoperative assessment, it is obvious the disease is just behind the nipple. This lady had a nipple sacrificing mastectomy through the lateral incision, and the same draping technique was used to reconstruct her. This is another technique where we use a lower glandular sling instead of the mesh, and usually these are patients who require nipple excision. So family history clinic day takes place once a month, and these patients have already been referred and have been seen by different disciplines, and we come together, we bring all the information under one roof and discuss about the suitability of the patient and mode of reconstruction if indicated. And this is one example in which the patient was BRCA2 positive. A bilateral mastectomy was performed, again using implant and assist by ADM. This is a photograph 6 months after her surgery. Now I've spoken about ADM, and I appreciate that ADM is something which is not used worldwide, but we had the same problem as ADM was introduced in our country. There were a lot of issues about its cost, but when you apply health economics, it is very obvious that ADM on the whole is, if it's not less expensive, it is almost equal to autologous reconstruction. So this is a comparison about the complications between ADM and autologous reconstruction. You can see the numbers: 104 in ADM and 77 autologous, which include TRAM and latissimus dorsi reconstruction. You can see the mean time of inpatient is 3 versus 6. Now we have gone down to 1 day. The complications at the end, if you look at, are almost equal, which is 9.6% in ADM group and 10% in autologous. This is a 5-year follow-up. It's not a short-term picture. Most of the complications were related to radiotherapy. In patients who had radiotherapy after the reconstruction had a higher rate of complications. Now, after analyzing this data, we do not offer these patients ADM-based reconstruction. We usually do a delayed reconstruction on these patients and use hybrid techniques in which we infiltrate the flap, breast flap, with fat prior to their reconstruction. And we found that majority of the CS complication, grade 3 complication, were associated with radiotherapy. Complications were not affected by the type of implant, and careful consideration is recommended when we are using implant in patient we think is going to have radiotherapy. Capsular contracture is scarring of the tissue around the implant, distorts the breast, has a reduced rate when we use ADM, despite the fact these patients are having radiotherapy. In our series, complications and downstream revision in ADM-based breast reconstruction in the absence of radiotherapy are compatible to other forms of reconstruction, and hence a very effective method of breast reconstruction with advantage of shorter theater time and quicker recovery. In summary, multidisciplinary approach has, in short, revolutionized the breast cancer management and probably has helped in reducing the cancer mortality. For patients and their relatives, the experience is more concise and less traumatic. With advancement in new techniques in patient care, sub-MDT are playing a vital role, and MDT in cancer care is absolutely vital. Thank you for listening.